Hello, everyone, and good afternoon. I would like to welcome you all to our presentation today. This is another in our Clinical Ed series under a UPL grant through the university. And the topic is the co-treatment of tobacco and cannabis use disorders. This is a rather timely, if underappreciated topic. Many people still feel that marijuana dependence isn't a real condition. And even when it is recognized, it is often not, or it's often given the same urgency as treating nicotine dependence, which is to say, not a lot of urgency at all, and certainly not as much as it deserves. My name is Jim Pavlik, and I am the Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. I'm also one of our lead trainers and curriculum developers, and I'm a nationally certified tobacco treatment professional. As we go through today's presentation, please feel free to chat in your questions or use the Q&A function. I hope that we'll have time at the end of the presentation today to answer questions as they go through, and we will hold those questions to the end. And at that point, depending on how much time we have, we will. You can also utilize the raise your hand function, at which point we will call on you, and you can unmute your line and ask your question live if that is your preference. With me today and kicking things off is Dr. Chad Morris, our director at the Behavioral Health and Wellness Program and a professor in the University of Psychiatry, the Department of Psychiatry here at the university. Chad?
Great, thanks, Jim. Thanks for introducing this webinar. And again, we are both from the Behavioral Health and Wellness Program, and so we are a whole health program that concentrates on a lot of different issues, but specifically, we put a lot of focus on tobacco use, and just recently I've been looking a lot at cannabis use among health disparity populations. And so if our purpose today, well, first I should say, just as far as conflicts of interest, we have no conflicts of interest. And our purpose today in looking at these, these two drugs and the co-use is we're really going to make the case that this is looking at treatment for both of these drugs is key to not only personal recovery for a lot of individuals, but population health gains if we're going to continue down that track, both for any kind of combustible product. And then we're going to talk about factors for co-treatment, really what the evidence base is, saying this is the way that we really should go. And then I'm going to turn things over to Jim in the second part of this presentation to really get practical and pragmatic about if we know co-treatment's the way to go, what do we do? So that's screening, brief intervention, and referral to treatment. And we're going to talk about co-treatment models for that, but then also opportunities. We're going to close out by talking about some resources and how we can optimize treatment by also focusing on policies, both for nicotine and cannabis-free treatment environments. And so in opening this webinar, we're really talking about an epidemic and a pandemic over the year plus that we've all been through. The tobacco epidemic has been with us a really long time. So going back at least into the 1950s, if not earlier than that. Marijuana and cannabis use, of course, we're going to talk about why that's becoming such a growing issue in the U.S., but globally as well. And so both of these things are, of course, also at the intersection of them. There's a lot of new devices like electronic nicotine devices, and that's what that picture you see in the intersection of marijuana and tobacco there, that makes it is really attracting new users, possibly to both nicotine and cannabis. But really again, a product that we know, again, with youth and adults both, is really potentially normalized use of both of these drugs. And then we're doing this at a time where we're in a pandemic. So we're in this very unusual time where actually the stressors of what individuals that use drugs or new drug users are facing increased stressors, and that's really pushing a lot of the use and the comorbidities and forward in that regard. And so what I'd like to do is just kind of unpackage this a little bit, do a little level setting, both on the tobacco front or nicotine front, and then also on the cannabis side. So if we look at smoking, so combustible cigarettes and combustible products, what you're really seeing here, again, is an incredibly positive downward trend in tobacco use among adults. And that's been the case with youth as well. But right now in the United States, we're seeing 14% of adults overall, an average of that across the US, are current cigarette smokers. And that's, as you can see, that's down. If you go back into the 1950s, that's down tremendously. And so this has been an incredible public health story, an incredible success. But what you're seeing on the top line, the dotted line, is that for a lot of health disparities, and the one we're focusing on today are those using marijuana and other drugs, that is not the case. And so we're really seeing that the prevalence of smoking among those who use other drugs is extremely high still. And there's a range there, but even if we average that out, and it's somewhere around 45%, 46%, it's extremely high. So we're seeing about a fourfold increase over the what we're seeing as the current adult prevalence rate in the United States. And if you look at what the outcomes of that are in the United States, we continue to lose 480,000. That's a conservative number, by the way, 480,000 people per year. It could be as high as 520,000 people per year in the United States due to tobacco. And I really like to, put that into perspective, in that we're about to reach, or at this point probably have reached 600,000 deaths due to the COVID-19 virus. And so, although that has been an extreme, we're losing a lot of people, we've been losing close to that due to smoking year after year after year, and that's continuing on right now. And if you compare that to all of the other causes of death in the US on the right-hand side, you'll see that again, putting into perspective just how high the cost of tobacco use and combustible products are. And that includes, if you notice, when we talk about the opioid epidemic on the right-hand side, and losing about 74,000 people due to the opioid epidemic, other drugs. And so that's factored into this as well. And then again, what you're seeing with that dotted line is that for health disparity population share a disproportionate amount of this unnecessary death and disability. So in this case, it's showing that about 200,000 of those 480,000 people per year are persons with mental illnesses and addictions that we're losing. And if you look at across addiction treatment programs, again, there's a lot of evidence out there, but this is just some of that evidence. I'm really looking at some meta-analyses over several studies, and this hasn't changed too much. So the last study being 2017, but if you go into prevalence in addiction treatment programs, you're going to find an incredibly high prevalence of smoking, and it's going to be somewhere in that 76% range still. So an ongoing issue that we face, and we still have a lot of work to do just on the combustible nicotine or tobacco side. And if you look, so let's switch gears and let's look at marijuana and why that's such a compelling issue right now. Well, we all know, we've heard that recreational marijuana is growing, and in addition to medical marijuana. And this is up to date as of yesterday, thanks to Jim. I mean, this is such a rapidly changing map that you see here, that the last state that passed recreational marijuana use was yesterday, actually, in Connecticut. So now we're up to 19 states that passed recreational, have legalized recreational use, and there's quite a bit more that, again, have medical use, or they've just decriminalized marijuana use somewhat. So the majority of the U.S., that's where we're at. So this is really, again, normalizing marijuana use, and it's making it much easier to obtain. But the message is kind of clear that it's, again, along with alcohol and tobacco, it's now one of those legal substances that a large population of folks use. And that's really what this slide is showing you globally compared to the United States or North America. So what you're seeing globally, if we're looking at ages 15 to 64, about 4% are users, and that means users are near daily users. Daily users are near daily users. There's about 4%. But if you then compare that to the US, we are far above that. So we're closer to 15% past year use in North America. And among those users in the United States, 1 in 5 is at risk for developing cannabis use disorder as diagnosed by the DSM-5, and that's a huge jump recently for those aged 18 to 25 years, and that has jumped up to 30 to 35% users are nearly daily users. And as we said, it's an epidemic and a pandemic. So during the pandemic, we've possibly seen a very, very significant increase, probably around 35% increase. And interestingly enough, when surveyed, most of those using are saying they're using it medicinally. They're using cannabis medicinally. And that makes a lot of sense if you think about it, because they're saying, it's due to the stress, the anxiety, the depression, the uncertainty of the year and a half that we've all faced together. And in addition, among young adult e-cigarette users, most of those are also using cigarettes. So they're co-users of cigarettes and e-cigs. And then a lot of those e-cigarette users, about half, are also current marijuana users as well. And just a few more stats that really lay out why this is such a compelling need right now is that 18 to 39% of adults who used tobacco in the past month in the US also use marijuana, which is a huge amount of crossover. But let's turn that on its head. Let's look at marijuana users, that among those, let's average somewhere around 73% of cannabis users also use tobacco in the last month. So there's a 3.6-fold increase in nicotine dependence among daily marijuana users that we're seeing right now. And so, given all of these statistics that I just shared with you, and I could share many more, but I think I'm making the case. If we go back to the Surgeon General report a few years ago, and he was talking about, what do we do in America with addiction? And one of the core messages was co-treatment is the only solution. That among polysubstance use, we need to co-treat. There's a variety of reasons for that we're going to get into a few of that, but this is a worthwhile report to take a look at. This report did not specifically call out tobacco or nicotine use, but there's a lot of other supportive evidence that's showing that we should not put tobacco and nicotine in a silo, and it should just be in the mix as far as how we're co-treating addictions. And part of why the Surgeon General reached this conclusion is that when we look at the psychosocial and the biological factors that are involved and make individuals vulnerable to any kind of substance use, they're the same, across the social. So it doesn't matter if it's tobacco, it doesn't matter if it's cocaine or heroin or marijuana. There's biological, clear biological vulnerabilities. There's clear psychological vulnerabilities, personality types, temperament types, and there's definitely, social vulnerabilities. So environmental stressors, peer networks, etc. That really put people at risk in childhood, and then they have that exposure to in this case cannabis. We're looking at cannabis, but the point is that this really applies for tobacco and cannabis, even though this is from a cannabis paper that we pulled this from. And so throughout childhood, throughout adolescence, if you start using cannabis early, you start using nicotine early, you're going to see the negative consequences of that much sooner. There's the stress, and at the same time, people might be experiencing stressors, traumatic events in their lives, etc. But they might also be experiencing protective factors. So we have to factor that in as well. But this is when you're looking at that green line headed up. This is saying, as we look at those vulnerabilities, and on top of that, as we learn both neurologically, our brain learns to be tolerant to these substances, and at the same time, cognitively, behaviorally, socially, we learn the triggers, the cues that really establish these habits. Then we get into these long-term consequences as adults. And there's very clear consequences both on definitely, of course, on the nicotine side, and equally definitely on the cannabis side as well for long-term use. So what are the key factors driving substance use disorder? And this again is across the board. We know, something that Freud, no matter what you think about Freud, he got a few things right. And what is, he really pointed out the importance of love and work. So relationships and work. And really that's getting into some of the key factors driving substance use disorder. We know that if you are bored, you are isolated, and you don't have meaningful relationships, or just a general lack of meaning in your life. You have irregular, altered daily routines, financial pressures. These drive a lot of substance use disorder, and these are things we have to address in treatment. And of course, the pandemic increased all this dramatically. So we had that just general uncertainty, whether it was financial, whether it was physical, that we dealt with, and in many degrees we're still dealing with right now. And so what are the consequences of this co-use? So we know that the biopsychosocial factors are the same. A lot of individuals, the overlap between this use is extraordinary. But what we know is that tobacco increases the addiction potential of marijuana and vice versa. So people use these, can use these drugs to really potentiate, the effects of the drug. But it's also neurological, of course. So as far as the cannabinoid receptors or the nicotine, acetylcholine receptors, they talk to each other. So they mediate each other in the dopaminergic response to these drugs, which is the reward system. And it might not be a direct impact, but definitely there's indirect impact on that. So and then that makes co-use of, when you're co-using, it makes quitting either of them very difficult, because individuals know about that, their body, well, both behaviorally and cognitively in their body. We know, what these two drugs are doing for each other. And so when we try to quit one, we often just substitute more of the other. And often this might be because as we're going through withdrawal for one of these drugs, the other helps control those withdrawal symptoms. So that's one issue that comes up. But in the other, just clear takeaway is that we know that over time, if you're using these drugs, they all lead to more stress, anxiety, and depression, even though a lot of times that's why people are using them to get away from that. I want to just really quickly touch on the fact that we pay a lot of attention to the negative effects of secondhand smoke from tobacco. We don't so much provide the education I think that we need around marijuana smoke, because it's just as dangerous in many ways, and sometimes in some circumstances it's more dangerous. It contains a significant amount of many dangerous substances that you're seeing on the third bullet down, and can lead to a lot of problems. So that's another just factor, not just for the person using combustible products, but for those in their environment as well, whether it's their family, friends, coworkers. The other really interesting thing as we look at co-use is that if you look at the DSM-5 and the withdrawal effects of either cannabis or tobacco, they're almost exactly the same. So this is what you're seeing. The only thing that is slightly different is that difficulty concentrating is a withdrawal symptom in the DSM-5 only for tobacco. Although I would say that I know a lot of people going through withdrawal from cannabis that have difficulty concentrating. But the outcomes as far as when these symptoms appear, the peak, the decrease over 2 to 4 weeks is the same. So it's just another kind of indicator of, hey, maybe we should be treating these things together because they are so similar in so many ways. And we also know that there's a lot of people that want to quit both of these. There's a lot of interest, and this has been shown time and time again. This pie graph is from one of the studies that we did in the addiction setting on tobacco, showing that the majority of individuals really that are going into addiction treatment for another reason, really want to quit smoking as well. So it's only about 25% that have no interest in quitting. And while that might be actually lower for cannabis, that there might be, that might be 30% or 35% that have no interest in quitting. There's still a lot of people that are interested. And so another indicator that we can do these things together. And then lastly, a really compelling study that was done quite a while ago in 2004. But we go back to this meta-analysis all the time, really showing that if you co-treat substances together, you're going to get a longer term increase in long-term, or better increase in long-term abstinence for that main reason someone came in for other substances. So this was in regard to tobacco. So if you go into an addiction treatment, you co-treat for tobacco, you're going to get a 25% increase in long-term abstinence. This meta-analysis didn't pull out cannabis specifically. It was talking about all drugs. But I think based on the evidence base that we're seeing, we can make the same case for cannabis. And with that level setting and that introduction, I'm going to turn it over to Jim to take us further.
Thanks, Chad. So as Chad mentioned, I'll be taking over from here, and I'm going to provide a general outline of what nicotine and cannabis co-treatment may look like in practice. But before I get too far along, I want to take a moment to reflect and expand on the point that Chad just left us with. Throughout Chad's section, there are two real clear takeaways, at least for me. And one is that the presence of problematic cannabis use is a pretty serious concern, and that growth in problematic use is probably going to go on for the next few years, at least, before it finds anything resembling an equilibrium. The other clear takeaway is that co-treatment means that treating cannabis use disorder at the same time as tobacco use disorder improves outcomes for both conditions, which is all to say that this is an important problem, but as was just pointed out on the last slide, it's also been a relatively overlooked problem by the broader drug treatment research community. BHWP prides itself on being an evidence-based program. Unfortunately, this is an area where the insufficiency of evidence is really just unrelenting. On the slide we have here, we see that behavioral health-related preventative measures that are rated so far by the United States Preventative Services Task Force, by and large, is mostly I's. I stands for insufficiency of the evidence. They can't make a recommendation one way or the other. They can't say that it's good and they can't say that it's bad simply because it really hasn't, most of these areas have not been looked at in great detail. And I want to point out the absence here, which is that treating marijuana specifically doesn't even show up on the board. And that's not to say there is no data at all, but it does sort of highlight the point that until very recently, some really important institutions aren't quite where we need them to be in order for us to act with confidence today. And that being said, we really do need to act today. Many primary care providers and researchers have been looking into the treatment of marijuana and into the co-treatment of tobacco and marijuana for a while. Between what Ched has already shared and what I'm hoping to share in the next few slides, I hope that you walk away today armed with an adequate knowledge of the fundamental notions underlying problematic nicotine and cannabis use, as well as their relationship, and also a rough outline of treatment approaches that way you can feel confident extending your current skills and knowledge into this critical area, providing the best possible treatment and care. So I'm going to talk about a few tools and strategies that work really well together. And I'm going to start with this one, the 5 A's. There are two popular frameworks that govern how a standard clinical encounter should go when a behavioral health issue is noticed and when the provider wants to engage the patient in treatment for that issue. In the substance treatment domain where cannabis use disorder resides, the dominant framework is called SBIRT, or screening, brief intervention, and referral to treatment. For tobacco, the dominant framework is called the 5 A's. And of the two, my personal preference is for the 5 A's because the acronym makes it clearer what the components of the brief intervention are. The 5 A's is an evidence-based best practice designed to treat tobacco use disorder specifically. It was originally developed by primary care physicians for use by primary care providers during a standard clinical encounter. It is intended to be brief, 20 minutes or less, and it has been shown time and time again in countless studies to significantly improve patient outcomes, not only in medical care sites like hospitals and clinics, but also in dental offices, pharmacies, community-based sites like Salvation Armies, and in community mental health and substance abuse treatment facilities. Not only is it good across sites, but also with a variety of professional classes delivering the intervention, and its use has also been expanded across a wide array of behavioral health-related concerns, including nutritional improvement and diabetes and blood pressure management. Which is all to say, if you can master the 5 A's, you have a skill that is transferable across preventative health concerns. And today we're going to expand its use into cannabis use disorder and cannabis and tobacco co-use disorders. And to do that, I'd like to share this common crosswalk between the two frameworks because marijuana is a new and growing area of concern. It makes the most sense to me to make the 3-part SBIRT framework the dominant visual element while defining the content of those 3 parts in 5 A's terminology. And so here we see that what SBIRT calls screening, the 5 A's calls ask. What SBIRT calls the BI, or brief intervention, we're talking about the 3 of the 5 A's, which are advise, assess, and assist. And finally, the RT in SBIRT is referral to treatment. And in the 5 A's, this is known as arrange. And here again, I like arrange over referral to treatment because even in the cases where we are referring individuals to care providers, we would still want to arrange follow-ups with the patient about that care. We may also want to arrange consultations with other of the patient's care providers to make sure that we are in fact providing precisely the level and type of care the patient needs, no more and no less. And one final and very brief note on why I prefer the 5 A's. The 5 A's are an evidence-based best practice, but they aren't magic. Each A provides a critical component of care, either giving knowledge to the provider so that the provider can appropriately tailor the education and the treatment the patient receives, or amplifying the motivation, readiness, and confidence within the patient so that the patient is equipped with the tools they need to undergo a difficult behavioral change. So while the 5 A's does in some ways make SBIRT more defined, we need to define it a little bit more. We know that the brief intervention is comprised of advise, assess, and assist, but how do we do those things and to what purpose? How does assessing the patient help the patient? What does it mean to say assist them? Assist them how? And for that, we need to turn to the evidence-based approaches that have been shown to work. The three on this slide are those specific ones that have a strong evidence base for the treatment of tobacco use disorder, and which also have shown evidence of being at least moderately effective in the treatment of cannabis use disorder. And those three things are motivational enhancement, and here we're primarily talking about using motivational interviewing in particular, or various scripted derivatives of that method, cognitive behavioral therapy, CBT, or prefabricated derivatives of CBT, and contingency management, sort of a blunt instrument, but an effective one. You can use any of these to address tobacco use disorder and be confident that in aggregate, they quote unquote work. More evidence is accumulating that using multiple modalities at once with clients actually has the best results. And this is even truer with marijuana, where the success of single-use modalities has been so limited that researchers have had to be a little bit more creative finding combinations that work. For example, a provider may start a treatment series with a motivational enhancement to ramp up the readiness and confidence necessary for a quit attempt. Then move on to deploying CBT to help the patients develop a better sense of their internal life and the power they can exercise over their behaviors. And then finally incorporating some contingency management principles in order to lock in positive decision-making, and in that process, shore the patient up against lapse and relapse later on in the series. In all cases, we know that education alone is insufficient to sustain quit attempts and maintain abstinence. Education is necessary, but insufficient. We should support education, number 3 on this slide, with self-monitoring and role play. These are tools seen most commonly when care providers are explicitly deploying CBT and/or mindfulness-based modalities, but they should be incorporated even if motivational enhancement or contingency management are really the main focus. Many of you may be familiar with the ABCs of behavioral change. The ABCs are where every B, behavior, is preceded by an A, an antecedent, a trigger, and every behavior is followed by a C, a consequent, a reward or punishment for that behavior. A, B, C, antecedent, behavioral, consequent. Typically, we can assist patients to change health behaviors by reducing the number or power of the antecedents and/or by altering the reward pathway. That is, diminishing the positive consequences and elevating negative consequences. Manipulating the consequent, if I'm being brief, is the main strategy of contingency management, which adds positive rewards like financial incentives for good decision-making, like attending counseling sessions, and adding negative consequences like jail time for bad decision-making, like failing a drug screen. This slide shows a slightly more advanced conceptualization of the basic ABCs. It's filled out with a deeper focus on the interior psychological dimension, those automatic thoughts in that middle green box at the bottom, that intrude, these automatic thoughts intrude between the antecedent and the behaviors. While also we see that the C, the consequent, is also more complex. It's more complex than behaviors alone, showing that the behaviors themselves are actually wrapped up with both emotional and physiological dimensions. And finally, we see in orange a third action domain outside the basic ABCs where meaning and understanding are imposed on the automatic reward chain. And that provides us, providers, another area where we can intervene by assisting the patient in creating a new narrative of themselves and their ability to make better decisions. I know this one can seem a little overwhelming at first, and indeed, a proper analysis of a patient's unique thought and behavior dynamic takes skill, intentional effort, and practice. I obviously don't have time to make everyone masters of the modality, and even if I had that time, I'm the wrong person to do that. That is way further up Dr. Morse's alley than mine. I would hope to leave you with this brief and simplified cognitive model. I just want to leave you with the idea that we do need to assist the patient to understand why they use drugs, and then assist them to find other ways, more helpful ways, to achieve those same goals. We don't extinguish behaviors, right? We replace them. So just as a good internalist seeks an understanding of the etiology of specific disease progression in a specific patient, the care provider seeking to address drug use should try to suss out some model of the patient's particular dependence so that she can properly address dependence in that patient. So I'm about to share 2 workflow outlines using references to specific tools deployed in an expert or 5A's framework. But before I do, I won't be blowing your mind by reminding you that adolescents are not just adults in smaller bodies. Dependent drug use is extremely complicated, and it is governed as much by the pharmacokinetic attributes of the drug as it is by psychosocial factors unique to each patient. Chad already mentioned this when we talk about the vulnerabilities and risk factors associated with any one drug are similar, sometimes even identical to the risk factors contributing to other drug use. The short version of this is that screeners and assessments that are validated on adults will fail to precisely or accurately identify dependence in adolescents. And whether a drug has been tested and successfully used in adults has no bearing on whether that same drug will work in adolescents. However, with some variability in the levels of success, our psychosocial counseling interventions, motivational enhancement, CBT, and contingency management all work with both, which contingency management and CBT work in adults and adolescents, and so does motivational interviewing. And I've saved motivational interviewing to be the last one I discuss for really two reasons. For one thing, it doesn't require, it is our preferred modality. And it's our preferred modality for a variety of reasons, but chief among them is it does not require an extremely complex cognitive model with multiple avenues for affecting change. It only requires the basic understanding that prior to making a change, an individual will in some way experience what we call ambivalence. The patient simultaneously wants to change and also does not want to change. They know that drugs are causing them problems, but the harms and benefits of use aren't quite imbalanced enough to tilt the patient in the direction of change. However, through education and dialogue, the patient can be moved into ambivalence, and once ambivalence is achieved or realized, the MI practitioner can use a variety of tools to help the patient further realize that they do indeed want to change and then motivate them to make that change. Which is all to say, just a super brief motivational interviewing 101, which is all to say the underlying theory of change is really just simple. And the tools of motivational interviewing, although they do require a lot of practice to master, they don't require a doctoral level understanding of the relationship between thoughts and behaviors. Anyone can do it. And good practitioners of MI score very highly in all of our bedside manner factors. Patients feel heard and respected. Providers are displaying compassion and honesty. All right, so the other reason I'm discussing the benefits of MI last is because they do have a central place in the workflow that I'm about to share. So very briefly, our adolescent workflow begins with a screener from the National Institute on Alcohol Abuse and Alcoholism. And as that name implies, this screener is designed to catch alcohol misuse or abuse in adolescents. However, positive screens on this extremely short, this two-question screener has been, positive screens on the two-question screener have been positively associated with marijuana use. I consider this screener, this two-question screener, optional. I would recommend it for busy clinics working with populations at lower risk for problematic use of alcohol or other drugs. Basically, the next recommended screener, the CRAFT-N, is much longer. And if you can successfully screen out a lot of low or no risk patients with a two-question screener, then it's probably worth the additional step. The next recommended screener is the CRAFT-N. The CRAFT-N starts with a couple basic screening questions. All patients will get those basic questions as well as the very first core question. There are 6 core questions, each designated by a letter associated with the key component of that question, C, R, A, F, F, and T. So all patients get the basic screeners and the C question, known as the CAR question. And that question is, and I'm not going to go through all of these, but just to give you a sense of what I mean by these letter associations. Have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? So anyone answering yes to that question then gets all the remaining questions. Anyone reporting tobacco use will also get the N questions, that is the nicotine questions. These questions are also the standalone tobacco screener known as HONC, H-O-N-C, the Hooked on Nicotine checklist. The CRAFT-N screener stratifies dependence and problematic use. The most severe cases, those scoring highly on the assessment or exhibiting signs of imminent danger, should be immediately routed to specialists. No or low risk individuals are celebrated and perhaps given some moderate education to support future good decision making. And those in the middle proceed to some motivational enhancement. In this case, we're recommending a scripted and audited protocol known as CHAT. CHAT has been shown in a few studies to improve patients' assessment of their own risk and also decrease their use of marijuana. And finally, after the intervention, we would either refer the patient to further care or simply arrange our next meeting with them. By the way, in our limited time today, this is as granular as I am able to get, but these tools, the NIAA screener, the CRAFT-In, and CHAT, can all be found online, or if you just email BHWP, we can get them to you. The example adult workflow is actually quite a bit simpler. Although if you're like me and you have all the 5 A's memorized, it looks like I'm advocating for skipping the ask and advise steps and going right to assist. And that's not actually the case. In fact, the assist on this slide refers to a multi-drug screener developed by the World Health Organization. So it's a name, it's a product. This tool is also available online. However, again, if you just email us, we can send you the PDF of this tool as well as a companion document on how to deliver a motivational intervention that begins with the assist screener. This assist, by the way, screens for multiple drug use. So it screens for heroin and other opioids and other specialty drugs, marijuana, nicotine, alcohol, etc. After using the assist tool, the provider begins with feedback about the score and what it means, along with non-judgmental, empathetic advice to quit. At that point, the provider asks for permission to go further, and if the patient agrees, they enter a motivational enhancing dialogue. Depending on what is discovered during that conversation, the patient can be referred to specialty addictions treatment or provided with strategies and self-help tools to begin a quit attempt on their own. Now, one thing I do always like to point out is that we need to make sure that each patient receives each of the 5 A's functions, which is why I had that slide earlier. However, it doesn't really matter which provider provides each of those functions, with one exception. In some instances, screening can be done during intake by the intake staff, or as is more and more common, on paper or tablets filled out by the patient themselves. Nurses and navigators are often better care providers when it comes to explaining dependence and guiding the patient through their various care options and to the ones that make the most sense for them. And of course, the front desk staff are ideal for scheduling those follow-up visits. The only 5 A's function that really needs to be delivered by an actual MD or DO is the advice to quit. Studies just show that when doctors advise patients to quit, the impact on the patient is just much higher. So all that being said, there are obviously certain other things that doctors might still be the best professional for. Questions about drug interactions, especially in complex cases, or in cases where the drugs are being used in an off-label manner, or just generally how engaging in a quit attempt may impact positively or negatively other elements of the patient's current health regime. Which is all to say that you can take the sample workflows on the previous 2 slides that I just provided and lay them out across the most common patient pathways in your clinic or hospital, ensuring that the patient gets their care from the most highly skilled practitioner needed for that particular function. What would be experienced as a high-intensity intervention by one busy professional is in this way experienced as a low-burden intervention by several professionals. And finally, if you were to adopt some version of these workflows, there are some things to keep in mind listed on this slide, some of which I've kind of already mentioned along the way and won't mention them again. One thing to note is that if you are interested in advancing your practice's engagement in drug treatment, especially with marijuana and tobacco, drugs whose persistence across the lifespan is long, you might also consider embedding the screeners that I just mentioned, or other ones, within a broader global psychosocial assessment. We keep returning to this point, but it's worth recognizing that encountering, experimenting with, and sustaining the use of a drug has several risk factors associated with it, and failing to address critical chronic risk factors means that relapse is just more likely. More and more PCPs are relying on strategies like quote unquote prescribing exercise or nutritional food, or using navigators or MAs to connect patients to these kinds of supports that address these social and environmental health factors. And to do that effectively, you really need to know if the patient has those risk factors. Confidentiality, of course, is sort of a no-brainer, but it is recommended to really go out of your way to make sure that patients are aware of these protections when you're dealing with drugs. And this is especially true with adolescents for whom all drug use is illegal or otherwise circumscribed. Also know that there is really no lower bound as to when providers can or should engage patients about drug use. While the average age of initial contact with illicit substances, including nicotine, is often in middle adolescence, there are cases where initiation and experimentation start much earlier. And in those instances, those are most frequently patients at multiplicative risk, which is to say that they are in the most need of early medical intervention and additional social supports to shore up their protective factors and enhance their native strengths. I've really covered most of the other elements on this slide, but I do want to emphasize that arranging follow-up visits is not just a good idea, it's necessary. With nicotine, we see increased abstinence when follow-up care is arranged. And with marijuana, what we see is that without follow-up, relapse is just overwhelmingly common. Technology can be leveraged to get better screening results, at least with adolescents, but there are other possibilities for technology. There is still a stigma attached to behavioral health treatment, and in particular among certain populations against getting treatment for drug dependence in particular, because being dependent itself is seen as either a weakness or a sign of some other character flaw. So telehealth is rising in popularity as a way for individuals to seek out help and receive treatment from their privacy of their own homes without risking having their cars recognized in the parking lots of behavioral healthcare clinics or nicotine anonymous groups. It is also the case that for rural and low-income groups, telehealth greatly improves access to care and can aid in the regularity of care, which is to say that one thing we learned during the COVID lockdown is that patients with access to telehealth missed fewer visits than patients without access to it. Finally, both tobacco and marijuana cessation has attracted the attention of various web or app-based designers, and several have shown roughly equivalent success in getting or maintaining abstinence compared to live interventions. And even to the extent that they sometimes don't do as well as live interventions because they are often cheap, the cost-benefit ratio often favors their deployment over more costly interventions that only offer marginally better outcomes. These options change pretty rapidly and their evidence base is pretty thin. I would encourage providers interested in this option to shop around and experiment themselves with what's available, and then work with your patients directly to figure out what's working and not working for them, and then sort of augment what's lacking. So moving on, I want to spend just a very, very few minutes talking about medication-assisted treatment. In the realm of substance abuse treatment, and with drugs for which there are FDA-approved medicines, MAT, medication-assisted treatment, has gone from a barely tolerated sideshow fraught with ethical dilemmas to what it is today, which is the gold standard level of care. And I'm not implying that there still aren't controversies or people who disagree with this approach, but the benefits of MAT and the harms of untreated drug disorders are simply just overwhelming those old arguments. In any case, treating tobacco use disorder with NRT, bupropion, or varenicline, NRT is nicotine replacement therapy, bupropion or varenicline is not often thought of as MAT, but I just want to say unequivocally right now, it is. And as with all the other MATs, the absolute best results come when we combine medical treatment with psychosocial education and counseling. For tobacco use disorder, we have 7 FDA-approved pharmacotherapies. 5 of these contain nicotine and thus are called nicotine replacement therapy. Of these 5, 3 are over-the-counter, available over-the-counter, the patch, gum, and lozenge, and the other 2, the inhaler and the spray, are prescription only. There are also 2 FDA-approved pharmacotherapies that do not contain nicotine, and these are varenicline and bupropion, both of which are available by prescription only. These drugs all work about as well as the others, and so providers really should just defer to the patient's preference, provided there are no strong contraindications for that preference for that patient. And actually, I'm going to offer some more caveats and thoughts about bupropion in particular in just a second. More and more, varenicline is being seen as the frontline medicine of choice, with the Thoracic Society being the first and most full-throated professional society to say so. For more information about pharmacotherapy for tobacco cessation, we have 2 good webinars on our website. One is sort of a basic overview of all of them. The second one, hosted by my colleague, Dr. Christine Garver-Apgar, is a more practical review of common issues related to use and ways providers can prepare patients to use these drugs according to their designs. Anyway, for now, there are no FDA-approved meds for cannabis use disorder, and this makes marijuana more or less unique among other major drugs of abuse. Nicotine, alcohol, and opioids all have multiple drugs at our disposal. researchers have looked at treating conditions associated with marijuana, like with sleep disturbances, as well as cravings and withdrawal and attention, to see if these targets would result in better abstinence rates. And some of the drugs that showed the most promise for treating cannabis use disorder have been, like bupropion, they've been antidepressants. In fact, bupropion itself has been researched to treat cannabis use disorder. And because this presentation is on co-treatment, it's worth spending a little bit of time on what the researchers have found. So in case it isn't obvious, this is where I was, this is the caveat I was alluding to earlier. Marijuana users prescribed bupropion in one study reported increased irritability, depressed mood, and sleep disturbances. This suggests that other contraindications aside and everything else being equal, providers treating nicotine dependence in marijuana users should stay away from bupropion, or might consider staying away from bupropion, as it may interfere with marijuana cessation, and could in fact increase their use of marijuana, as Chad mentioned, to overcome these negative effects. And I'll add, though, that the study had a small n, like it was a small population of people, and another study did not replicate those results. In fact, there were actually a total of 4 studies that I'm aware of. And in the 2 best ones, the 2 biggest ones, these additional problems also did not arise there. However, they had really big dropout rates. So in those studies, the differences in measures of both withdrawal and cravings were not significantly different between control and experimental groups. And the end result of the studies is that bupropion at least is not effective in improving abstinence from marijuana. And given the results of the first study mentioned and the high dropout rates that I just mentioned, it's possible that bupropion actually actively increases relapse. So several of the drugs in various classes, including cannabinoid agonists, hypnotics, anticonvulsants, and mood stabilizers, have all been tested for cannabis use disorder. And to date, unfortunately, no drug is being recommended, even for off-label use, to treat cannabis. You're seeing on the screen now a 2018 study that highlights the targets of various drug treatment attempts, but we also have studies from 2016 and 2019 and 2020, all of which repeat the same conclusion in this paper, which is essentially no dice. And maybe even worse than that, the very few drugs that have been tested in regard to marijuana use often decrease mood stability or increase anxiety, which may adversely impact the nicotine side of any co-treatment plan, which is to say that for now, the best strategy for medical co-treatment that is a pharmacotherapeutic co-treatment, is to treat tobacco use with NRT or varenicline, but deferring to NRT, and co-treating marijuana and nicotine together via the psychosocial modalities that we've already described. Actually, that is I'm going to move into the final section. I'm just going to leave you with a few resources. I'm not going to spend a lot of time here, and that way we can move into Q&A. The first is, if you are in the position, if you are working with a CQI, continuous quality improvement team, or if you are in charge of creating new workflows, adapting old workflows, the paper presented here actually shows how to use a PDSA process to incorporate SBIRT, an SBIRT style model, into primary care. PDSA, for those unfamiliar with it, there's a ton of acronyms for these sorts of things, but it's just essentially a rapid improvement process. It's very popular. It's been used in the medical healthcare industry for nearly 40 years. PDSA stands for Plan, Do, Study Act. Sometimes you'll see it referred to as PDCA. That's Plan, Do, Check Act. You'll also sometimes see it used, referred to as the Deming cycle. That was its original name a long, long time ago. So any of those things are all the same thing. They're this thing, which is PDSA. Very simple style process, and I recommend it if that is in any regard part of your job. A lot of evidence-based guidance out there for tobacco treatment. I'm biased, but I'm going to recommend that source on the left. You can find that for free, downloadable from our website. That's the Tobacco-Free Toolkit for Healthcare Providers, giving you a pretty strong fundamental introduction to the evidence base for treating tobacco dependence with a focus on the healthcare setting. On the right is the first out of 4 volumes for treating cannabis use among adolescents. This 4-volume set is really informative, goes into a lot of detail of exactly how these interventions were tested. It specifically looks at CBT models and motivational enhancement and incorporating family into the treatment regime, and also community-based resources. You can find that all 4 of those books at the website listed there, although if you just type the title into your Google, you're going to find it elsewhere as well. Another cost-effective option for some places, it's sometimes harder to incorporate into a hospital setting, but other types of settings should be encouraged to consider adopting a peer model. Peers in substance abuse are highly effective, almost exactly as effective as professionals in most cases. And if you're curious about what designing a peer-based program looks like, the toolkit recommended there is also ours and freely downloadable from our website. And the American Lung Association has a billing guide. We want you to be able to keep your lights on. This billing guide is primarily for tobacco use, but some of those billing codes in there are going to be transferable to other intervention styles. We do always recommend incorporating treatment models for patients along with a parallel process that gives education and training to staff and also protects visitors, clients, families, everybody else on a campus. This is our tobacco-free policy toolkit. And so even though it focuses on tobacco, we do encourage you to consider elevating your language such that it incorporates prohibition on the recreational use of marijuana, either combusted, eaten, or vaped on campus as well. And finally, do check out the National Behavioral Health Network for Tobacco and Cancer Control. This is one of 8 sister agencies looking at the topic of tobacco and cancer control within 8 subpopulations of concern, and this one is the one that looks at the behavioral health population, which of course would include those individuals suffering from substance use disorders, including cannabis use disorder. And that moves us, we have about 5 minutes for questions.